So as a net effect of the last 2 days, I'm starting to get the feeling that almost anything we do is an obesogen, right? Being inactive, eating, drinking beverages with sugar, drinking beverages that don't have sugar, brushing our teeth. It's just truly daunting. So I'm reminded of how with so many issues in environmental health, we do wind up with this situation where there are many upstream factors that are influencing our health. And it's easy enough to, point to one or the other. And I often hear this among my faculty, by the way, the problem isn't what you eat, it's that we're not active enough. And no, you can't be active enough to consume all those extra calories that we're eating. And I hear these debates all the time, but I think what's becoming apparent to me is that our health is being impacted by a multitude of factors. And in fact, you'd think that we'd all be obese after hearing all this. And I guess that we've practically gotten to that point. So perhaps that is the reality. But one of the things I wanted to lead off with, when we talk about this concept of environmental exposures and obesity, and we use a term like obesogens, which does imply that we're talking about weight and we're talking about fat. But what I keep hearing you coming back to, and I heard this also from some of the earlier presentations, is not so much a concern about weight and fat, but metabolic changes and changes that are pointing in the direction of actual disease causation. And I thought maybe I could ask actually the four of you to reflect on that in terms of your research.
Since yes, obesity is increasing in prevalence, and it's a problem, we have been trying to solve this problem, and apparently we are not able to solve it with eating less and exercising more, because what we accept as healthy food is also somehow unhealthy. So an obese population, healthy normal weight population is as sick as the obese population. So being metabolically healthy or unhealthy is the problem. So in our last study we just completed, we enrolled African American and Latino obese population who are metabolically unhealthy, and we screen them on for their metabolic parameters like insulin resistance, fasting glucose, their lipid, liver fat accumulation, and we keep them on the same number of calories for the 10 days, and we then repeat the tests, and just in 10 days we cater their food, so we know that we are catering them the food we are preparing, so keep the calories same. And at the end of the 10 days, we show that their metabolic health improved.
Yeah, Christine.
In a way, I feel that we're concentrating then on a very privileged group. There's a privileged group of people who carry their weight well and have probably modifier genes that make them less susceptible to cardiovascular health, diabetes, and so on. But in terms of population research, what we're interested in, I feel we do need to accept the fact that, in general, adiposity is associated with increased inflammation and clinically associated with more cardiovascular risk. Not everybody needs a statin, not everybody needs to lose 50 pounds in order to be healthy, but I think in general we need to accept the fact that obesity is associated with certain health conditions, and that's what we're after, and there are a few people who are exempt. We have tried to start a study, not necessarily on the metabolically healthy, but we've tried to start a study on people who can so-called eat whatever they want and they don't gain weight, because we thought these are the people from whom we need to learn how this is possible. The problem is the study was halted and actually totally stopped because we couldn't identify them. Because once you examined them carefully and you looked at their lifestyle supported the amount of calories they actually ate. They were more physically active than they thought.
Yeah.
They actually didn't eat quite as much as they thought. And so, in fact, the opposite, namely these people who can just eat whatever they want, we haven't found them. If you have, we'll open the study again.
Charles Bailey, did you have a comment on that?
So I think one of the things that strikes me as these conversations go on, and that you hear in more and more contexts, is we talk about associations with obesity, and that's particularly a language that we use in the health services side, perhaps less so in the lab side. But I think that underscores perhaps an important relationship between adiposity and the kinds of health consequences that we'd really like to avoid, right? And from a pragmatic perspective, the association is very solid, and I can do some of my clinical or population management decision making without really understanding the causal link by effectively treating adiposity as a biomarker for a set of health consequences. But I also wonder if on a methodologic level, what we need to do is focus on the possibility that the adiposity may also be an effect of some of the underlying metabolic drivers here. And that doesn't... Yeah, I don't mean that in a way that alters our understanding of cellular physiology, but more in the sense that we look a lot at the adipogenic effects of various environmental or genetic factors, and I find myself wondering to some extent how much the obesogenic effects and the adipogenic effects may not be on the same critical pathway.
Nick Durandar, do you have a response?
Yes, I have two quick points to make. Thank you. One was just to add to what was discussed is, yes, we need to focus on metabolic consequences of obesity, but that's not the only consequence of obesity. There are numerous other comorbidities or adverse conditions that are linked with obesity that we may overlook if we only focus on diabetes or cardiovascular disease. A person may look healthy in terms of diabetes, not having diabetes, but the mechanical load of carrying that extra weight on joints, weight-bearing joints, for instance, just as an example, or other relationship with cancer or numerous other concerns that one needs to consider, and not only focus on metabolic aspects of obesity. That's just to add to the discussion. And the other part was left, I could not complete in terms of response earlier, that was about various factors working together. When we are studying a factor carefully, of course, we have to try and isolate that factor very carefully and just make sure that there are no other influences that we are studying. But in nature, that may not be the case. That factor may be working in combination with other factors. A good example of that would be, there was a study that comes to my mind published from Washington University about celiac disease, and very quickly, in their animal models, it turns out they needed 4 different factors to exist at the same time for that celiac disease to be expressed, and that included a mutation, gut microbes, some sort of insult or injury to intestines, and norovirus infection. If you took out even one of these factors, there wouldn't be an expression that they wanted, and all 4 needed to be present. Or even pollutants, environmental pollutants, and respiratory infections, exaggerating each other's effect. So I think that's one thing to keep in mind, that there may be things that may work in combination and not just work individually.
Right, thank you. I think we have a question or comment from the webinar audience.
Yes, I have a few questions from the web. So two I'm actually going to combine because they're related. One question was from Janet Young and the other one from our speaker, Nick Durander. So the first question is, I'm sorry, those were two wrong individuals. The first one's from Nick, and the second one is from Yutaka Aoki. So the first question is, if antibiotic exposure is a marker for infections, could one say that there's greater obesity in children who have more infections? And related to that, could the association that we're seeing with the use of antibiotics be arising from confounding by indication, where antibiotics are involved, could have been involved for prescribing a so-called obesity-causing pathogen?
So I think both of those are very interesting questions, and we can only get at them indirectly with the kinds of population studies that we've done. I will say that in the health services study that we did, we were able to look at the diagnoses that were made for children, and two interesting things appeared. One is there was not an association between obesity and diagnoses of things like colds, upper respiratory infections, or that sort of thing. The second was that when you included in the multivariate analysis, diagnoses of infections like otitis media aren't associated separately with obesity once you account for the use of antibiotics. So, in light of the fact that, for instance, close to 90% of ear infections are viral in origin, I think it's less likely that what we're seeing is that groups of kids that are more susceptible to clinical viral infections are basically also more susceptible to obesity, and the antibiotics are a confounder there. It's a hard thing to tease apart, right? The average child has about 10 infectious illnesses a year in infancy and toddlerhood, and so there certainly is not an unexposed population. I think the question of whether antibiotics are being prescribed to treat obesogenic bacteria, so basically what you're seeing is a marker for a population that's colonized with those kinds of bacteria, is mechanistically a really interesting one. Again, it's harder for me to think that specifically the kids who get antibiotics are preferentially colonized with these strains of bacteria, because typically the antibiotics aren't prescribed based on microbiologic isolates. They're prescribed based on symptoms. And as I pointed out, about 2/3 of kids are receiving some antibiotics. But I do think there's a real question about whether there's a subset of the population who may be more susceptible to things like antibiotic effects, because the pathogen, the commensal mix in their microflora is more susceptible to perturbation in an obesogenic way. So, while it may not be strictly confounding by indication, there may be a stratification in the population that we can't really appreciate because we don't have a detailed view of the microbiome.
Any other comment? Oh, yes.
Just if you allow me an anecdotal comment, and that is that I would just like to support the notion that we don't treat based on any evidence for a bacterial illness with antibiotics in children in 90% of the cases. In also bringing up the question is, this is going to be so hard again to tease out socioeconomic factors that are beyond just socioeconomic level. And the anecdote I wanted to say is a study came out of Kuwait and trying to pinpoint where the Kuwaiti childhood obesity came from and what it was associated with. And the strongest factor was maternal employment. Mm. And the reason why I'm saying that is, in my brief career as pediatric resident, I have heard almost all the time that you need to give me an antibiotic for my kid because I need to go to work tomorrow and the daycare doesn't accept my kid if the kid's not on antibiotics. So I would say, with this, just anecdotally, but this just highlights how difficult this will be again to tease out other factors. And when you talk about maternal employment, then our kids at home, then you know that you don't supervise what the kid is eating right now. You're not playing with the child instead of the child maybe in front of the television. It just goes on and on and on. So these factors of why children get antibiotics are so diverse and difficult to capture.
I think that's very true, and I can't underemphasize that. I also don't want to miss the professional factors too, right? And you mentioned things like parental or administrative need to be on antibiotics. We think, although we haven't proven that part of what's driving the increased use of broad spectrum antibiotics are things like once daily dosing, right, rather than twice or 3 times a day, that sort of thing. There have also been studies that have shown that younger pediatricians are more likely to follow clinical guidelines that include lower antibiotic prescription, and we've thought a lot about the degree to which that reflects how close you are to training, or whether there are differences in the way we think about public health. But I also don't want to miss the reverse, right? Much of what drives things like antibiotic prescribing for ear infections has been assessment of the risk of secondary infections such as meningitis, and the landscape was completely different there 20 or 30 years ago. So within the practice lifetime of some pediatricians, and now that strains like H. flu type B and even several pneumococcal serotypes are no longer common in the population due to successful immunization strategies, we need to rethink how we approach some of these common infections, because the likelihood of the rare but catastrophic secondary consequences are lower, and that affects the risk-benefit balance for things like antibiotics.
Yeah, it's a complicated issue, isn't it, clinical prescribing? We had a second question.
Yes, so one more. So it's related to probiotic treatment, and this is from Janet Young. So the question is, have the speakers thought about how probiotic treatment may either complement antibiotic treatment or take the place of antibiotic treatment, and then how this may affect obesity going forward?
Any thoughts on probiotics? Yes, we do have one. I can see.
In fact, again, one of my colleagues has tried to summarize the evidence recently for probiotic treatment and, for example, a decrease of certain infections or, in fact, in his animals on obesity. And unfortunately, there's very little evidence. It starts with the difficulty, and this will surely evolve, in which bacteria are being used at which doses. And when you go and you buy probiotic products, the difference in the bacterial counts and types is enormous, and it's therefore extremely hard to get true evidence-based answers to these questions. But I guess this will evolve.
I mean, I have seen studies by consumer groups showing that some of these preparations don't actually have anything alive in them, and so it's kind of interesting, because I can remember a time when it was just very clear that artificial sweeteners would be helpful, right? And they were marketed for that, but never because there were any controlled studies that proved that. And now we see the same thing with probiotics and many other things that are on the market, well out ahead of where there's any evidence. Whole other very interesting, yes. Well, you're going to have to get in line. We have a next person at the mic.
Jack Spangler, Harvard and Roundtable member, and very informative 2 days. Linda, thank you so much for hosting this. This has been really great. That was my question. It was about probiotics. So I found myself here, so I have to think of another question. But Christina, a number of people showed trends throughout the last day and a half. One trend sort of caught my mind when I was listening to your talk, and that was the decrease of soda consumption. Starting to fall off. What's replacing it? And the millenniums are drinking Red Bull, right? They're drinking energy drinks in massive quantities. I mean, kicking the day off with a shot. ending the day with alcohol mixed with energy drinks. Anyone paying attention to this? What's in it?
Yeah, so the trend was really interesting during the time when there was more soda drinking. The consumption of milk went down in kids. So less milk, more soda. For the last few years, the soda industry generally, whether it's sugar-sweetened or artificially sweetened sodas, is struggling because there's a downward trend. In the United States, so, in fact, you might have heard that Coca-Cola and Pepsi came out and said that they will decrease their sales, and they make their products smaller now. And this is all in order to help us with dealing with the obesity epidemic. Instead, when you look at the curves, you see that that is the projected sales curves that they would have anyway. So they're just saying we do this. But going from there, yes, so what has switched is, in fact, children drink more fruit juices and so-called no sugar added drinks, and these are the drinks that contain artificial sweeteners. So there's a clear shift away from sodas, diet, or sugar sweetened. It's a very interesting trend.
Okay, the next questions from the audience here.
Yeah, I wonder if people are willing to speculate a little bit. I think there's a complete consensus across all of our disciplines that obesity is not good, that it would be excellent to get rid of it. And we've heard a lot of different perspectives on what kinds of things might be contributing to that. And we heard our chairman comment about the fact that you can't escape. It's in the toothpaste. It's everywhere. I wonder if anyone is willing to make recommendations. So there is no useful treatment for obesity. So saying it's no good is like saying, I wish there wasn't so much snow in Boston. But it's an effective strategy to cause any kind of an improvement. And you talk about people going to the grocery store. What kind of advice should you give to people about how to conduct their eating lives?
Great question, and why not we do a rapid round through each of the speakers to see what if anything, you advise. I mean, what do you advise your friends, your children, or in your professional life? Do you want to start? Aisha? That is your professional life, so Aisha.
We're all kind of putting our all effort to avoid the exposure to any kind of toxic substances in our daily life, but eventually we can escape to some point. But I do personally in my life, I'm trying to, I have almost 3-year-old, so I'm trying to not to introduce him the artificial sweeteners or any sweet or salt. And I think I'm trying to consume healthy real food, which is unprocessed food. I'm trying to cook from scratch, and I kind of define myself successful because about a month ago I took my son to a birthday party, and this is the very first time that he's gonna show a real cake, and there's a birthday cupcake for each kid and with the frosting. So everybody just tried to just jump on the cupcakes, and my son asked me to scrape off the frosting because he never had one before. And his friend sitting next to him was saying, "Oh, you should eat that one. It's the yummy part." And my son, "No, mommy, yucky. Take it out." I take it out. He even tried it. He got the first bite, and I should have recorded it. And he screamed to the host, "Sophie's mommy, this cake is yucky. It's not good." And he take the cake and throw in the trash can. So I feel myself that I'm giving the good notion to him, but
Good start.
Yeah.
Perhaps as the mother of an 18-year-old.
Eventually he will just go.
Perhaps Nick Durandor, do you have a response to this one?
Yes, thank you. Dr. Corker brings out an excellent question. And here is what I think about this. I believe that we don't know enough about the disease obesity. We have been trying for last 50, 60 plus years, and perhaps we are just beginning to understand what complexity this disease has. So currently we find ourselves in a situation we are similar to treating, let's say, cancer or HIV, when there are the two things that I would like to separate is what causes obesity and what we could do about it. So the treatment and causation are not necessarily one and the same things, and they may not always be the same things. We restrict gluten because in celiac disease, but gluten doesn't cause celiac disease, or lung cancer may be caused by smoking, but stopping smoking is not the only treatment for lung cancer. You need to do something about it. So cause and treatment could be two separate arms, not always going together in opposite directions, so to say. So coming back to cancer and HIV, for instance, we don't have the best treatment there is for these diseases and many other diseases. But that doesn't mean that we stop treating cancer or tell people that go away, come back after 15 years when we have better drugs. We treat them with what we got today, knowing fully well that that's not the best treatment, so we go back to research. We try to find out what are the causes, what would work, what would be a best drug, and then we come back and offer that. I think that is where we are in terms of obesity treatment right now. We have a blanket treatment to offer for obesity today, which is no matter what causes we heard today or yesterday, the treatment is eat less, move more. For some lucky people get drugs and few individuals get surgery. And that is almost always regardless of the cause. And that is the best treatment we got today. And that is what we continue to offer, need to continue to offer clinically speaking. But then that is what underscores the need for research so that we can consider all these causes, contributory factors, and come back with a better and really effective, biologically meaningful treatment and prevention strategy that can take the weight off meaningfully and keep it off. But we're not there yet.
Charles Bailey, did you have a response?
So I'm afraid that the best I can offer at this point is moderation in all things. It seems to be the case that for most people, this is very much a multifactorial problem. And while we can diagnose the end state well, it's much more difficult to identify the particular combination of factors that's most important for a given individual. And so I end up recommending a balance, a balance in diet, a balance in exercise, a balance in activity, and to steal the line from Mark Twain, a balance in balance too. It's useful not to become so preoccupied about the prevention strategy that you become ineffective in practicing it because you're so worried about the occasional departures. That's not where I'd like to be. I'm much happier with Nick's vision of the future, where we have enough information to really deflect the course more easily. But at this point, the best advice I can offer to people is moderation.
And Dr. Rother, did you want to add anything before we go to the next question?
What I wanted to say is, since we have relatively little evidence, for example, with the artificial sweeteners, when I'm being asked, can I have a soda here and there? Is this bad for me? Should I stop completely? We don't have enough evidence. So I really want to tone this down and say, let's see. In effect, I agree with you with regard to moderation. I don't think that the occasional exposure to artificial sweeteners is going to make you clearly obese. I think this is, again, the big picture on which we need to work. And in there, I'm partially hopeful because you have managed to expose BPA as one of the endocrine disruptors, and we've gotten rid of it in our water bottles, right? No, I see some.
Yes, BPA is no longer, but we've got other things that
Yeah,
may be
of
worse.
course. No, but all I wanted to say is the consumer does have, it seems like, some weight in expressing what we want. And therefore, I'm somewhat optimistic that we can request that our food choices, our environment, and this is the built environment. This goes way beyond there. I agree with Nick that we should go beyond just focusing solely on food, that might get better. But then I want to give this question back to Barbara, because she showed us that our food, the so-called, the unprocessed one, the natural, the rice that I can go and buy, that has changed. So what can I do?
See, that's really mean now. I'm very appalled by the fact that we give advice all the time as professionals in our field, for which there's no scientific evidence. And it has been on occasion proven wrong. For example, our focus on lipids has been all wrong. Poor eggs suffered for many years, and now I think the poultry farmers are going to have a comeback. But those comments were based on non-evidence, and I cannot give any advice as a scientist knowing there's no evidence. So there's no evidence. Even the work that I've done, the work that I believe all of that, have no problem with it. But we really don't know what causes obesity, and we really don't have anything useful to treat it or cure it, except for, as Nikhil said, we can do surgery, and there are some medications that have small effects. But I think we need to find out. I think that's, and I think we need to find out what's in our environment. And I would love to see a system in which we all work together and that we put our mental energy into trying to find solutions and make it clear to the public that we don't know what we're talking about, and they shouldn't listen to us. But they should instead fund us to do research.
Linda.
Thank you. We always appreciate pressure for more research. We'd certainly like to be able to fund more research. But I also think that we don't have to always wait for complete 100% understanding and certainty before we take action. And in fact, I think there is quite a lot of information that coming from a multitude of different directions, where you take the mechanistic studies and the animal studies and the observational studies and the few clinical interventions kind of trials that we have, and you put it all together, and there are certainly some warning flags that we need to look at. But Barbara, the question you first asked was, what do we need to do about it? And I think we all know that individual behavioral change is much less effective in the long term than public policy changes. And you know, the public health approach is always going to be more impactful in the long term. I do want to say, since you brought up BPA, I mean, the reason that it was really removed from baby bottles, it may still be in some other bottles, is because of marketplace pressures. The same thing with some of the flame retardants. That's what led to the removal, not actual regulations. And so there's lots of data on some of those things. We don't have to be paralyzed by the lack of certainty. At times we have to try things, and sometimes we'll make mistakes. But I do think that when you walk into the grocery store, 95% of packaged food products have high fructose corn syrup. Now, you tell me why, if I buy a jar of supposedly, you know, fresh jelly or jam or something, which is going to be sweet because it's got fruit in it, why does that have to have high fructose. I mean, you can walk through, why do the cereals, and the high fructose corn syrup, though, of course, just one thing in the packaging. You've also got lots of different kind of preservatives, some of which are now being taken out because of growing concerns. You have all kinds of other additives. So the real issue that I think we face is, I think most of us know that fresh foods are probably the healthiest things, but they are not available to the entire population, especially maybe the people who, from disadvantaged backgrounds, who are most at risk. So that doesn't solve any answer of what we should do, but it does address some of the problems.
I can't help myself. I observe, my daughter and her friends. I do advise them of things such as do not chew through an entire pack of sugar-free gum all in one sitting, because that isn't the way that FDA thought that you would use this gum, but it is the way they do it. Anyway, sorry, but we have a
question.
Can we take
from
one question, because we have to.
Yep, and then one behind. Yep,
Yeah.
And it's related to the high fructose corn syrup issue that Linda just mentioned. So this comes from Janet Young, and she notes that she had on colleagues in 2013 published a paper talking about that many pathogenic gut bacteria were resistant to glyphosate, whereas many beneficial bacteria were susceptible to it. And the question is, since glyphosate is widely used in conventionally grown corn, which is subsequently turned into high fructose corn syrup, could glyphosate exposure in the gut from conventionally grown corn crops be a confounding variable in the results with the link between sugar or fructose and metabolic dysfunction?
Right, so this is a question about the herbicide glyphosate, also called Roundup, which I'm not sure that any of the presenters know very much about. I know a little about it, and I think it certainly that factor hasn't been measured in the studies that were presented today. So I think it's a worthwhile question to explore. There are tiny amounts of glyphosate residues in food that are not considered at this stage by EPA and other authorities to be of concern, but they haven't been looking at these particular endpoints. So I think it's a fair question. Perhaps to go to the next question.
Scott Auerbach, NTP. One of the things that strikes me about artificial sweeteners is they, at some level, reach the level of pharmaceutical in my mind. They're administered at a dose that binds to a G protein-coupled receptor that then activates a signaling cascade. Yeah. And most of our drugs are actually G protein-coupled receptor targeted, right? And one of the things that you noted, Christina, very early in your talk, is that these receptors are expressed in many different areas of the body. Now, some of these artificial sweeteners are not readily bioavailable, so the dose that you get is relatively small internally. But there are some that do get in, and presumably at a dose that's not too far off from what activates the taste receptors in our mouth, which motivates us to consume it. So it's probably binding to these receptors on other organs, assuming it gets there. And as a toxicologist, while I know we're dealing with obesity here and diabetes, what other things have these receptors been shown to be involved in? And what other biology have they been associated with beyond even just obesity and diabetes? And I don't think that question's really been asked, because we've just started to notice that these things are expressed in all these other tissues just of late as we've started doing genomic analysis, things along those lines. But I was wondering if anyone has any thoughts on that, of what other possible functions these taste receptors could have.
So there are two lines of thought, and I was quite surprised to hear one line of thought from one of the leading experts, Nick Reiber, on taste receptors. He actually thinks this is all nonsense. Taste receptors in the lungs, taste receptors on the wings of flies. He thinks that these are not at all taste receptors, that these are receptors made up, the taste receptors made up of two parts, and that this has really nothing to do with taste at all. And in fact, that these so-called taste receptors in the lungs are not stimulated by neither caloric nor non-caloric sugars or substances. Now, this is one part of the discussion. The other part says there are clearly these receptors expressed in various tissues, and the problem is that we don't know what they do in these other tissues, and that, for example, there is a question whether sweet taste receptors in the lungs have something to do with asthma that we do see that can be worsened by certain, for example, by obesity. So that there's a lot being debated with this regard. But I wanted to make just one point, because you said that most of these artificial sweeteners are at least absorbed a little bit. They're all absorbed except aspartame, which is broken down into aspartic acid and phenylalanine, and that's why it shouldn't be taken by people who have PKU. But every other one is clearly saccharin, absolutely absorbed, sucralose, 20% absorbed. They're all being absorbed. So I fully agree with you that they might qualify as really pharmaceutical agents.
Thank you for that. Any other responses from our speakers? If not, we'll move to the next question at the mic. Hi.
Bernie Goldstein, University of Pittsburgh, member of the Roundtable. We've been talking about what to do, how to respond. And I think when we do that, we need to think about co-benefits as well. These things aren't isolated. Some of these are obviously hedonistic. I can't quite articulate the co-benefit of chocolate, but I know it's there. But clearly exercise, one could make a case that exercise has so many other benefits besides weight, and obviously for all the folks, perhaps osteoporosis, balance, whatever. The processed food, as much as we can say negative things about them, are cheaper. And that's a real co-benefit that must be considered if you're going to really start thinking about how to take action. So I just wonder if restricting our approach to co-benefits based upon these really superb presentations we've heard, or based about actions, that we really need to expand it beyond what we've just talked about to these other issues that really are, I can see our economist basically raising his hand and saying, yeah, these are important too.
I agree with that. Any comments on that, though? Oh, yes.
May I quickly comment, and then it would be interesting to ask the economist. Now, in fact, some of the pediatric studies have been done in looking at this economic factor, and it is debatable whether the packaged food is in fact cheaper. Because if you cook from scratch, as my colleague does, admirably, you may in fact save. The only thing that you don't save is time, and we don't have time. And in many families, we don't have culture to cook and prepare the food, and we could in fact save money. Also, this especially in DC, we have the Ward 8, where there's no corner store anymore, where you can buy fresh vegetables and so on. But ultimately, it seems to be a minor factor in the food choices. In fact, even when there is a corner store, what is being bought is the pickup at the fast food place. So it seems to be more a choice than being forced to eat packaged food. And so maybe we should almost downtone a little bit the economic factor with regard to food choice, and say it's just inconvenient.
Thank you for that. I think I have time for one more question, and then we'll have to break for lunch.
Janet Hall, NIHS. I wanted to kind of come back to the somewhat nihilistic tone that was kind of permeating the meeting a few minutes ago, and really think about, I think probably primarily what, in response to your talk, Christina, is that I think that one of the important things that has come from this group of people being together and has come from the weight of evidence that you reviewed today, for instance, is that artificial sweeteners are not necessarily safe. And I think that's actually a very important thing that the public at large is not aware of. There's been little bits and pieces of that have kind of come around, but I think that we as scientists actually have an important role in communicating those kinds of messages. first of all, I don't think that sort of saying we don't know anything and therefore we need more money is going to get us more money, because, we've spent a whole lot of time and effort trying to figure out what we do know and what we don't know. But I think there's more that we can say than you're giving credit for. And I think that those are very important things for the public to understand, is that, we think it's safe, but it may not be as safe as we think. And therefore, this concept of moderation may well be one that really has to win the day.
So, before we break, I think one of the interesting insights that I think I've received over the last day and a half is that, number one, the time may have come for some kind of a consensus study by the National Academies about this issue of obesogens. There's so much more here than what we had known, and we're going to talk about this further after lunch, both in terms of the research directions that might be pursued, but also policy. And I think that those are going to be wonderful discussions, but also specifically on the artificial sweeteners and along the lines of what was just said. That's also an excellent topic right now for a consensus report. And I would hope that perhaps the FDA would be interested in that, because these are findings that have emerged post-market and can be addressed and should be addressed. And I recently was involved in a study that they sponsored on caffeine. There's a lot of caffeine in the food supply now. A study on sodium. There's a lot of added sodium. And so I do think, and I will certainly provide a copy of our links to our presentations and our discussion to them. I do think that this is an area that's going to need further exploration. It's very interesting, and I really appreciated also the comment about the toxicologic implications of what we were hearing, which is very fascinating. One last comment from Dr. Birnbaum, and then we are going to break for lunch.
So I just wanted to mention that there have been long-term animal cancer studies done on some of the sweeteners, and aspartame and the asulfame. And those studies, while not perfect studies, have shown positive responses, but they've basically been ignored. The European, or a group in Europe, are now doing another long-term study on some of the artificial sweeteners, I believe. And so I think that, when we totally ignore animal data, I think we ignore it at our own peril.
Well, with that cheerful comment, we are going to
enjoy lunch.
We'll return in an hour. We'll return at 20 to 1, and please be thinking about research needs and policy solutions while you're eating.